Today in pathophysiology, we're talking about neoplasia. So what we're really talking about here are cancers and cancer tumors. According to the National Cancer Institute, an estimated 1,735,350 new diagnoses of cancer will be made in the United States in 2018, and approximately 609,640 people will die of cancer. Cancer mortality is higher in men than women. In 2017, 15,270 children and adolescents up to age 19 were diagnosed with cancer, and 1,790 children died of cancer. Currently, the most common cancers listed in descending order, so the highest number first, are breast cancer, lung and bronchial cancers, prostate, colon and rectal cancer, melanoma, bladder, non-Hodgkin lymphoma, kidney cancer, endometrial, leukemia, pancreatic, thyroid, and liver cancers, which if you look at the chart here on this diagram, it pretty much shows that those are the ones that are being listed. Although this slide is called neoplasia, we're going to start out doing just a little bit of review. Proliferation is what we need to form new growth. And we might phrase proliferation as cell division. It's how the body keeps up with the cells that are dying or have been damaged and replace them. And one of the interesting things about neoplasia is that we have a profound amount of proliferation. And we're going to talk a little bit more about that in just a couple minutes. One of the things that's really unique about neoplasias is that the cells don't tend to die off. The apoptosis just doesn't seem to happen as frequently with them. And so we don't have this balance of cells. We have too many because they just keep forming more and more and more, but they aren't dying off as easily. And we're going to talk a little bit more about that as well. With benign tumors, they are given the name of whatever the tissue was that the tumor formed from, and then they're given the suffix of "oma." So you might have a glioma. It came from the glial cells, and it's benign, so it's a glioma. These cells are very well differentiated. Remember, differentiated means that they look very much like the cells of the organ that they started out from. And they look very organized. Other things that happen with benign tumors is that they tend to grow very slowly, and they may even have periods of times where they stop growing altogether, and then maybe they start growing again. They also grow by expansion rather than by invasion of the surrounding tissues. And so they stay where they are. And you may have a little lump, but it's very well-defined lump. They also don't spread throughout the body. They don't metastasize. And this has a lot to do with the fact that they don't invade the surrounding tissues. With malignant tissues, when we look at how they're given their names, if it's from the epithelial tissues, it's going to be that tissue name plus the carcinoma. Or if it comes from the glandular tissue, it's going to be that tissue's name and then adenocarcinoma. If it's mesenchymal tissue, which means it's going to be soft tissues, it's going to have that tissue and sarcoma. One of the other things that mesenchymal tissue makes is bone. So you may have an osteosarcoma. These malignant cells, very much less differentiated. They're very atypical in their structure. They have very little resemblance to their tissue of origin. The cells often do not mature normally, so they're immature. They don't differentiate, which means they aren't able to do whatever the job was that that tissue was supposed to do. So if it's a white blood cell that they came from, they don't act like white blood cells at all. So they don't fight infection or do what they're supposed to do. They just grow and make a mess. They have rapid growth, and it's, again, undifferentiated and faster. They grow by invasion of the surrounding tissues. They put out little tentacles and grow into the other tissues that are surrounding the organ that they started out in. And they gain access to the blood and lymph channels and spread to other areas of the body, and we call that metastasis. One other thing I wanted to mention, and I waited till the very end to say it because I wanted to be able to make sure that you'd understand it. In the benign tumors, their edges are very smooth. So often they're described as being round or oval, but if you were to look at them, the edges are very well defined. If you look at malignant, I used the term of tentacles that were going out, and their edges are very irregular, they're sharp, they're jagged looking, and really kind of look like tentacles going out into the tissues that are surrounding the tumor. And that's something that makes them very unique when they're looking at a localized area. For instance, if they were looking at a lump in a woman's breast, if it was very smooth looking, the radiologist would probably anticipate that that was going to be a benign lump. Where if he looked at it and it had all these sharp, spiky things coming off of it, it would be a much more strong indicator of it being a cancerous tumor. Some of the other things that we look at as far as growth is concerned with cancer versus normal cells is that they secrete growth factors, or they may have more receptors. The other thing that seems to happen with cancer cells is they lack cell density dependency, or what they call contact inhibition. So in other words, in normal cells, when the cell gets to the edge of wherever it's supposed to be, it stops growing. It says, enough is enough, we're getting too crowded here, let's stop. Where the cancer cells, they just keep going. They go and go and go, and they don't care that things are getting crowded in their area. They're just going to invade and make more room. And so they end up causing more constriction in the area that they're growing. There's also a problem with anchorage independence. So in normal cells, they anchor themselves to the epithelium inside of where they're supposed to be. Well, one of the things that happens with cancer cells is they don't anchor them. That's one of the reasons why they're able to float around and go all over the body. They also have faulty cell-to-cell communication. Yeah, our cells actually do talk to each other, and so they don't tell each other that things are getting too crowded or that they need to stop growing now because things are getting too tight in that area. The other thing about cancer cells is I wouldn't really say that they're immortal, but they live much longer than the normal cell does. Their telomeres are longer, and so they can divide more often and for a longer period of time. They have less, this has higher telomerase. So that is what in the cell division allows these telomeres to separate and form new cells. So they just tend to last a lot longer, and they don't die as quickly, but they're replicating faster than the normal cells. In our last slide, we talked a little bit about growth factors. We're going to talk about it a little more here, along with the idea of tumor growth. So cells divide only when they're told to do so by growth factors, and those growth factors have a number of different methods that they're done. And the growth factor causes stable cells to enter the cell cycle and to divide. It also stimulates this cell density dependent inhibition and the cell-to-cell communication. Well, what ends up happening with cancer cells is that they actually they can continue to grow even though they don't have growth factors going on around them stimulating that growth. Not to mention, some cancer cells produce their own growth factors, so they don't even need this exogenous source of growth factor. Not only that, but they don't have that contact inhibition, and so it just continues to grow and grow and grow. Tumor growth is dependent on the number of reproducing cells. So we know that in tumors we have a higher number of cells present. The more cells that are present, the more chance you've got that you have reproducing cells rather than resting cells. We also have to look at the duration of the cell cycle. And what we know about tumor cells is that they tend to have a faster duration of their cell cycle. Some of that has to do with the fact that they are producing more immature cells and less mature cells. Not only that, but we have to look at the number of cells that are being lost in relation to the new cells that are being produced. So what we know is we're producing an overabundance of new cells, but yet at the same time, we also know that these tumor cells have those longer telomeres, so they're living longer, or what some people are saying immortal. So that's making this tumor grow faster as well. If you look at the little chart at the side, it talks about billions of cells. But if you look at the number of doubling of cells in the tumor, at the top of the picture, it shows like a half centimeter turning into 1 millimeter, turning into 2 millimeters, 4, 8, 16. We're doubling. Whatever number of cells we had there at one reproduction, now the next reproduction we have twice as many. And then we have twice as many of those. And then we have twice as many of the others, because we don't have these cells that are dying at the same time. So what we see as expressed on this chart is that by the time we're getting up to around 22 or so doublings of cell numbers, we have a very dramatic uptick in the size and number of cells that are in this tumor. Metastasis happens when the cells in the primary tumor develop the ability to escape that tumor, travel either through the blood system or the lymphatic system, survive in those solutions, exit those systems, and develop a secondary tumor somewhere else in the body. It's really kind of an amazing thing. And if you look at this drawing, it shows how those cells invade the blood vessel, kind of make an emboli, and then the platelets attack it and kind of keep it together, taking it to another part of the body where it somehow attaches along the side of the blood vessel and escapes that blood vessel, making a tumor somewhere else. One of the other things that you can notice here is it talks about angiogenesis. Remember that every tumor, any cell in the body has to have oxygen to it, and it needs those ATPs to survive. So these tumor cells, when they get somewhere else, they've got to make new blood vessels to provide oxygen to their growing tumor. If they don't get blood flow to the tumor would die, and they want to keep alive, so we have this angiogenesis. Genesis meaning creation, so creation of blood vessels. And some people will actually call this new creation of blood vessels where they weren't previously neovascularization or new vascularization. Although neovascularization is usually refers to more where new blood vessels are formed where the previous blood vessels have been blocked off or destroyed. So just to kind of tell you about that as well. So we've talked about, and you probably read, how cancer has many different ways that it's thought that it can happen. And we've talked a little bit about how mutation can cause this normal cell to become abnormal in its function. Well, one of the ways that they think that that may happen is with cancer-associated genetics in the cell. So we know that we have these proto-oncogenes that are in normal cells. They code for growth factors, they code for growth factor receptors, they code for transcription factors, the cell cycle proteins, and the apoptosis inhibitors. So what we know with that is this keeps the cell functioning normally. Well, there can come a point where these normal cells, that their proto-oncogenes mutate and become oncogenes. So now, instead of just making this normal cell work, now they've turned that normal cell into a cancer cell. And they do it by changing the DNA sequences of that cell. It can do it by putting insertions in, it can do it by deletions, it can do it by translocations, and that can cause increased or activated areas in the cell to happen and change things. So for instance, it may cause tumor in the oncogenes. We usually see increased function, and so what we end up having are these increased duplications. So one of the examples of these, like the insertions changes, are the RAS. The Philadelphia chromosome refers to deletions. The HER, which is the human epidermal growth factor receptor 2, is an amplification or an overexpression of a tumor cell. Then we also have these tumor suppressor genes, and they inhibit cell division. And we want that in a normal cell. But when mutations happen, they actually cause this to be overexpressed or to be underexpressed so that we continue to make more and more and more cells. So one of the enzymes that we have is known as a P53. Your book refers to it as guardian of the genome, which I thought was kind of interesting. You sort of see an outer space thing when you think about that. It prevents the propagation of genetically damaged cells so that if there's a mutation that inhibits the P53, then there's going to be an increased release of mutant and cancer cells. So think back to when we were talking about cell division and the RNA and the DNA sequences. We know back from studying that there's a point where these tumor suppression genes would see this abnormal tumor cell and would say, oh, wait a minute, I don't want that cell to be around here. It sends out signals, and eventually we end up with those macrophages coming in and engulfing and getting rid of those tumor cells. You know, every day we make tumor cells, but it doesn't mean that our bodies are full of cancer, because our body takes care of those cancer cells, those tumor cells, by our immune system seeing them as abnormal and they're not supposed to be there. But these tumor suppressor genes are making it so that that mutant cell is not reproducing itself. So when we get when there's something that acts on, for instance, this P53 enzyme, then we end up with this mutant cell reproducing and reproducing, and now our immune system is having a hard time keeping up with it and getting rid of these cells before they become a major big deal for us. So you can see by the answer to this that the answer to that question was false. The rationale is that the statement that was made was describing the proto-oncogenes. Oncogenes are mutated proto-oncogenes that code for abnormal proteins. So we would not say that they make normal cell activity. Instead, they make the abnormal tumor cells. There's 3 stages of carcinogenesis. Remember, genesis means creation, so creation of cancer. The initiation is the initial mutation that occurs in the cell. So if you look at this illustration here, you see the normal cell. It is possibly being attacked by chemicals or radiation or some kind of virus, and some DNA damage and cell mutation has taken place. So promotion is when that mutated cell is stimulated to divide. Well, we may end up with a perfectly okay cell. On the other hand, we may end up with this mutated cell. That's where we start moving down into progression. And progression is when the tumor cells compete with one another and develop even more mutations, which makes them even more aggressive in their growth. There's a number of host and environmental factors that come into play in the development of cancer. We can look at Mendelian inheritance in genes. For instance, the BRCA1 and 2 that we see with women that increases their risk of breast cancer. In fact, it's to the point where if you test positive for BRCA1 and 2, you pretty much know that at some point in time you'll develop breast cancer. And in fact, not only will you develop it sometime in your life, but often at a young age. When we look at reproductive hormones, we often see changes in or the effects of estrogens or testosterone on developing cancers of the reproductive organs, the breast, the prostate, the uterus, the cervix, um, and other organs. We know that when people are obese, then it has a number of effects on the body. And metabolic syndrome and um, diabetes is one thing that we know that can have mutagenic effects on the cells, and that increases the risk of cancer again. But also with obesity, we find that people have higher levels of hormones. We often will see men that have developed breasts because they have higher levels of estrogen that is directly related to obesity. And so, again, back to the idea of the reproductive hormones, the obesity causes an overexpression of these reproductive hormones, so it also increases the risk of cancers in those organs. Um, when we look at immunity and tumor antigens, uh, if your immune system is not up where it needs to be, you have a much higher risk of developing cancers. And if you're not producing the tumor antigens that are decreasing the number of tumor cells in your body so that your immune system is going in there and gobbling them up and killing them off so that they can't reproduce, you're going to have a much higher incidence of cancer. Then there's the exposure to chemical carcinogens like cigarettes and alcohol. And we know that there are certain foods, and especially food additives, that increase risks of cancer. So, we want to avoid those as much as possible. Uh, Ionization in radiation, we have already talked about how that changes the DNA of the cell, and by changing it, it causes that mutation, and that increases the risk of it being a tumor cell. And then viruses and bacteria. There are 70 different types of HPV, and we know that there's about 4 of them that have been shown to definitely cause cancer. There's quite a few that don't cause any kind of cancer at all, but they cause other things in our system. And because a lot of HPV is associated with cervical cancer and penile cancer, we know that this is a sexually transmitted disease. And so we have to look, we have immunizations against HPV now. And, some people sit there and they fight getting any extra immunizations, but it definitely is something that could reduce the cancer risk in some people. We know that Epstein-Barr is associated with cancer. Hepatitis B and C can weaken the liver and cause mutagenic changes within the liver that can result in liver cancer. And there's also this human herpesvirus 8 or HHV8 that when somebody who has AIDS acquires it, that they develop Kaposi sarcoma. The one that I found kind of interesting was to read about this HTLV1, which causes T-cell leukemia, and it mentions that it's primarily in Japan. But if you think about the way that we travel in the world right now, you know good and well that it's not going to be very long until that's going to be something that's all over the world. Especially since we know that it's related to the HIV virus. Then there's also, your book gave one example of the Helicobacter pylori and how it can cause certain types of gastric cancers. And, you know, as you read the literature, we're starting to see more instances of how viruses and bacteria are causing cancers. So what happens when we get tumor growth locally, right where that tumor is starting to grow? Well, the first thing it does is causes compression on adjacent structures. So when we're talking about hollow organs, we talk about the stomach, we talk about the lungs, we talk about the heart. And if you think about those organs, as the tumor gets bigger, it starts to compress them. If you have compression of the lungs, it means that you're not going to be able to breathe as well, that you're going to feel short of breath. If you have compression of the heart, or you're not going to be able to pump blood as effectively, so your patient may be lightheaded from it. Think about compression of the blood vessels around it. With that, we may see ulceration and necrosis from the compression that these tumors are causing, or we may, because your body is dynamic, and you know, even though we draw pictures of everything just sitting just so inside the body, the organs inside the body are moving as well. So as these tumors are pressing against the blood vessels, they can erode the um, the walls of the blood vessels and cause bleeding. It may just be localized bleeding that then clots over and it's not a big deal. However, depending on how big that hole is, it may actually cause some massive hemorrhage. Not to mention that we can have effusions that happen. These are fluid in either the pleural, which means the area around the lungs, the pericardial areas, which is the area around the heart, or the peritoneal spaces, which is the area around the bowels and the abdominal organs. So this fluid around there uh, is often related to obstructions of the lymph system, and it becomes leaky and it leaks that lymph type fluid out into those areas. Of course, if you have fluid in the pleural area, it's going to make it harder for the lungs to expand. If you have fluid in the pericardial area, it's going to make it more difficult for the heart to stretch and to beat adequately. And depending on how much fluid is there, it can greatly reduce the stroke volume of the heart. In the peritoneal area, we often see fluid that is there because of ovarian cancer. In fact, that fluid is usually the first sign of the ovarian cancer. And in many cases, it's already metastasized by the time somebody is aware of this fluid that they have in their abdomen. And then, of course, we have systemic manifestations of cancer. Anemia is often associated with cancer. This can arise from blood loss, from iron deficiency. You notice the next thing we have down is anorexia. Well, if you're not eating well, you probably are not getting adequate iron in your body, and so that can affect your red blood cell count. It may be related to hemolysis, especially if you have some type of cancer that's affecting your red blood cells. There's going to be more destruction of those cells. It may be related to impaired red cell production. If the bone marrow is affected, it may may not be producing as many red blood cells. Again, remember that when these tumor cells take over, they take over, and then there's not as many of the cells that are actually doing the job that they're supposed to do. And then in some cases, it may actually be the effect of the treatment to treat the tumor that causes the anemia. Anemia is normally treated with iron supplementation and erythropoietin. Erythropoietin stimulates the bone marrow to produce more red blood cells. And if that isn't sufficient, they may receive blood transfusions as well. The anorexia and cachexia, it tends to be more common in children and the elderly. There's multifactorial causes, so that doesn't mean that all of these things have to be happening for it to happen, but just a few can be happening in the body, and the person will have these symptoms. They believe that it may be an effect of persistent inflammatory response. Remember, the inflammatory response is how we get rid of those abnormal cells. And when you have inflammation in your body, you don't really feel very good, so you don't really feel like eating and doing those things that you would normally do. Production of cytokines, this tumor catabolic factors, and abnormalities in taste. If things don't taste the way they ought to taste, and in many cases you'll hear people talk about having metallic tastes in their mouth, and they just don't feel like eating because no matter what they try to eat, there's this metallic taste. That can either be the cancer itself or the medications that are treating it. They feel that in some cases there's a suppression of the satiety centers. So it's the part of your body that says that you're hungry, it's time to eat, and now you're full. Well, they aren't working right, so you don't feel like you're hungry at all, but you're really breaking down the proteins and everything in your body. And all of these things can be accentuated by the treatment for the tumors. Some people suffer from fatigue and sleep disturbances. And what they find is this fatigue that they have is not relieved by rest or sleep. Now, whether some of that may be related to their anemia or their anorexia, that's a possibility as well. We just know that people with cancer tend not to sleep well, and they tend to have a lot of fatigue. Then there's ectopic hormones or factors that are secreted by the tumor cells themselves, and we call this paraneoplastic disorders. And these are actually diseases that we look at in the endocrine system itself. So SIADH, where ADH is being affected, Cushing's syndrome, hypercalcemia. The cancer cells may produce proteins that affect clotting, so they bruise easily. And then there's also these paraneoplastic neurologic disorders, so feelings of numbness or other abnormal neurological symptoms associated with it are often systemic manifestations of cancer. Your book did a really good job of talking about the cancer diagnosis and screenings. Some of the things that we may look for are tumor markers, like for instance the prostate-specific antigen. So these are blood tests that we do, and if we see that they're elevated, then we do more investigation. We may do cytologic studies like a pap smear where we take cells from the area and look at them under a microscope to see whether those cells look normal or not. Pap smears are considered a screening tool and not a true diagnosis because we have to do additional testing afterwards. Tissue biopsy, where we might either do a fine needle aspiration, and when they say a fine needle aspiration, what they're talking about is taking a very thin needle. So in other words, very large number gauge needle, and putting it down into the tumor, drawing up cells into the syringe, pulling back on it, making those cells from that tumor come up into that syringe, and then putting those on slides and examining those cells under a microscope to see what they look like. They're getting really good at these things. They're using ultrasound and other techniques to know exactly where some of these tumors are. So they're actually doing even abdominal kinds of biopsies in this fine needle aspiration method. But you really have to have something that's not going to move around, that you can hold still to be able to do fine needle aspiration. Other tissue biopsies may mean that we take a little bit of the tissue itself. For instance, if you have melanoma, they may actually just remove what they think is all of the abnormal cells and then send it for analysis. And if they see that all of the cells that there's a good border on it, then they know that it's good. But if there's not a good border, they may have to go back and remove additional areas in order to get all of the melanoma that was on the skin. On the other hand, they may do surgery and remove the tumor itself and look at the tumor and find out, was it a benign tumor or was it a cancerous tumor? I had a nodule on my thyroid, and they went in, removed it in surgery, did all the real quick look at it while I was still out in surgery, and said, "Oh, everything's fine. Sew her back up again. It's no big deal." Well, when they started doing their very specific looking at the thyroid millimeter by millimeter, they discovered a tiny little 2 millimeter cancer in there. And, because thyroid cancer tends to be very encapsulated, it was not a big deal because they had taken out the whole thyroid, and so there wasn't any of it out on the edges. There was no sign of it anywhere else except this one little teeny tiny piece. We just did additional follow-up. My surgeon told me that if he had known that that was there, he would have taken the other half of my thyroid out. Well, we discovered that that side looked fine when we did additional testing. We may do immunohistochemistry. So with that, we use monoclonal antibodies to identify cell products or surface markers for certain carcinomas, for malignant lymphomas, melanomas, or sarcomas, because they tend to look really similar, but they need to be identified for what they really are because the treatment is different for them. And so if you don't know specifically whether you've got a lymphoma or a sarcoma, you don't know how to treat it and treat it most effectively. We also are doing some things with microarray technology and gene chips. And so it's really, cancer treatment is changing so dramatically, really on a day-to-day basis, as we're discovering more and more ways of getting to specific cells and treating them. This table is in your book on page 147, and it just looks at tumor markers and where the source was and the associated cancers that go along with them. So like for instance, the first one is the alpha fetoprotein, and it comes from the fetal yolk sac and the gastrointestinal structures early in fetal life. The primary cancers that are associated with that are liver cancers and germ cell cancers of the testes. And so it just it's an interesting thing to look at, and it gives you an idea of specific markers that may be looked for in diagnosing cancers. So there's a lot of things that people get confused about, and the grading and staging thing is one of the things that especially non-medical people get confused. They don't really understand what the difference is between the two. So when we do grading of a tumor, it is a microscopic examination of the cells and the differentiation. Remember that benign cells look very much like the cells of the organ that they came from, and they look pretty organized, where the differentiation of a cancer is very abnormal. So what we see is if something is graded as a 1, it's considered well differentiated. So we're looking more at a benign tumor in that case versus a grade 4 where everything is very poorly differentiated and we can tell that these are definitely cancer cells. In addition to grading, we also do staging. And staging is when we take a combination of the clinical symptoms, the clinical assessments, the x-rays that we've done, the surgical examinations, the biopsies, everything that we've done, and we've looked at the extent and the spread as far as it relates to treatment and prognosis. So TNM is one method that we stage. And if you look at what this means is T stands for tumor size, N stands for regional lymph node involvement, M stands for metastasis. So when we look at the tumor size, it gets graded on a 1 to 4 stage. So 1 is small, 4 is big. When we look at lymph node involvement, 0 means it's not in the lymph nodes. 3 means that it's well entrenched into the lymph nodes. Metastasis, it either is or it isn't. 0 means it hasn't metastasized, and 1 means it has. The higher the number on this TNM scale, the more serious and poor the prognosis is. And that's what you really need to know about staging. Your book calls the next method of staging the AJC, but its technical name is AJCC, and what it stands for is the American Joint Commission on Cancer. Their stages are 0 to 4, looking at the size of the primary lesion and the presence of nodal spread and metastasis. And you don't need to know the details of how they do all of that. And I know that your med surg book goes into a lot of detail about how it's this, if it's this size, and there's this much node involvement, and there's no metastasis, and it's this stage if it's that, and it's that stage if it's not. Most instructors, and I would make a general assumption that Dr. Mitchell is going to be the same way, really just wants you to understand that the higher the number of staging, the more serious the cancer is, and the prognosis is lower, and or poorer, and the treatment is going to have to be will either be much more aggressive, or they may choose not to do much treatment at all, just comfort treatment based on those numbers. We're going to talk a little bit about cancer treatment, some a little more than others. So surgery, we've already talked about how it can be used as a diagnostic tool and for staging the tumor. Obviously, we can use it to remove the tumor in some cases, or in other cases where it's considered to be inoperable, we may use it as palliation. For instance, if we had a very large tumor in the chest that was putting a lot of pressure on the heart, on the blood vessels, and the lungs, we may do what they call a debunking uh, procedure, where we take a large amount of the tumor away so that it's not putting so much pressure on the lungs and the heart. They still have an inoperable, maybe stage 4 cancer, and they probably are still going to die. But this palliative surgery has made them more comfortable in their final days. Radiation therapy, it may be a primary method of treatment. It can be used preoperatively to help shrink a tumor. It may be used postoperatively to make sure that um, they're able to kill more of the cells that they weren't able to get during the surgery. It can be used with or without chemotherapy. It can be used on its own without surgery. Chemotherapy, I'm not going to spend a lot of time talking about because we're talking about it in pharmacology as well. But it's a systemic treatment. It's used in the primary treatment, often used as a primary treatment. And like we just mentioned earlier with radiation and surgery, that it may be used as part of a multimodal treatment plan. If you look at this little graph next to you see a line up there at 10 to the 9th power that's above it. It says clinically overt disease, so that's when we're getting symptoms. It says underneath the disease is in clinical remission. So this red line, we start treating with chemotherapy. And maybe during the first cycle of chemotherapy, we see this big decrease in tumor cells. Usually there's a little break in between one cycle and the next cycle of chemotherapy. During that time, we may get a little bit of cell regrowth. So a little of the cancer comes back again. Everyone gets really, disappointed. They hope that these cells are going to be dead for forever. But remember, they're overproducing all the time. So they get the second cycle of chemotherapy. Now the cell numbers of cells have dropped even further. And we have a little break, we have a little regrowth, so we have a little tick up on that. So now we're getting another cycle of chemotherapy, and we kill even more cells. And if we continue through all the cycles, we can end up with potentially no cells, cancer cells. However, if you see this little dotted line going off from the red lines off towards the right-hand side of that illustration, it talks about what would happen if you stopped doing your chemotherapy too soon. In this particular case, they're saying, what if we didn't do the 5th round of chemotherapy? And you can see that we would have a very rapid regrowth. That little bit of upswing that we had would just continue to grow exponentially. And imagine how quickly it would grow and return right back to where it was, and even higher levels if we had stopped therapy even sooner, maybe after the second round or the third round. And that's why they watch very closely the cell levels as they're giving chemotherapy. One other treatment that's out there is hormone and anti-hormone therapy. These are specifically for cancers that are responsive to or dependent on hormones for growth. And they have specific hormone receptors on the tumor cells. So these are things like breast cancer is, there's several different versions of breast cancer that are very hormonally receptive. And so women that have those type, they cannot be on birth control pills because it would actually encourage their breast cancer. We also see it in prostate cancer. There's quite a few of the prostate cancers that are hormone receptive responsive. Another type of cancer treatment is known as biotherapy. And it's when they take monoclonal antibodies, and with those antibodies, they're able to block the major pathways for tumor cell survival and proliferation. They can modify these monoclonal antibodies to deliver toxins to, and when we say toxins, we're not talking about toxins to the good cells, but toxins to these tumor cells. They can also deliver radioisotopes so that the radioisotopes are killing off these tumor cells. They can deliver cytokines or other cancer drugs. It's really kind of a cool thing because these antibodies are very specific to the type of tumor cell that they're trying to attack. And then there's cytokines specifically like interferons and interleukins that are known to naturally kill off tumor cells. Then we're a developing way of treating these cancer cells is targeted therapy. And these are drugs that target these tumor cells specifically and leave the normal cells alone and not cause any problems to them. As you know, some of these other chemotherapeutic drugs kill not only the cancer cells, but it kills off the normal cells as well. And there's a real fine balance between giving enough drug to kill the cancer cell, but not too much so that you kill all of the normal cells as well. So with this targeted therapy, we're starting to see treatment that's able to specifically treat specific cancers. Finally, a word about childhood cancer. Childhood cancer tends to be in the hematologic, the nervous tissues, the soft tissues, or the bones. It usually stems from fetal tissue cells almost exclusively. The incidence is greatest during the first years of life, and if you think about it, that's when we're closer to those fetal cells making the new cells. Usually there's no early warning signs or screening tests for these types of cancers, and they spread very quickly until finally the child is having symptoms. I have a friend, her little boy's 4 years old, and all of a sudden he just started having headaches. And soon the headaches were causing him to vomit. And when they went to the doctor, he could hardly be driven to the doctor's office, and they did MRIs and tests looking at his head and why he would be having these headaches, and found this large brain tumor that probably had been growing in his head since he was an infant. Often the treatments that we give for childhood cancer can cause cancers later on in life because, again, these cancer drugs and cancer treatments like radiation causes mutations of their own. It kills off what we're aiming at, but it may cause other long-term changes that happens years later.